everybody, and welcome to our AIHI seminar series. And look, it's my great pleasure today to introduce Serena Joyner to you all. Serena is the Consumer Engagement Manager at Health Consumers New South Wales, and she's an experienced facilitator and project manager. But really it all didn't begin there. Serena hails from the Blue Mountains, where she is the leader of a group called Blue Mugs, which is actually the biggest ukulele, she's a ukulele rock star basically, and she hosts the biggest ukulele festival in the world in Katoomba every year. So I just want to say, you know, I really wish she had a ukulele with her today, because that would have really topped her. But you know, we'll just have to imagine. Yeah, okay. All right, so, you know, yeah, so in addition to that, what else should I tell you about Serena? Well, look, she's actually also got a Bachelor of Chemical Engineering, so she's come from a non-health field, but obviously has been very closely engaged in health research and engaging consumers in health services and health research. She has recently actually been working with WentWest as well, which is the PHN in the Blue Mountains area, and she produced a new consumer and community engagement model with them in 2015. She's had a lot of experience over the years working with what were originally the divisions of general practice, which then became the Medicare locals and are now the primary health networks, and she's also engaged a lot with local health districts. So really a wealth of experience to share with us about what it's like to be a consumer and engage with health services. So I'd like to introduce Serena, and thank you very much. Over to you. Okay.
Hi everybody. I would like to begin by acknowledging the traditional owners of the land on which we're meeting, and to pay my respects to their elders past and present, and particularly pay my respects to any Indigenous people who are here today. But I would also like to acknowledge if there's anybody here who works in the capacity as a consumer representative. They work very hard, sometimes for some reward, but often for no financial reward. But while we're on that subject, I'd love to get a sense of where you're from. So would you mind raising your hand if you come from a health service or a health organisation? Great. And if you come from a research university organisation? And who's doing both? Who's actually crossing both? Fantastic. Well, it's great to have you. Thank you for coming. Yes, this presentation I do want to talk about evolving models of health, consumer and community engagement. Evolving is one of the key words there, because there's certainly no set theory or set science here. And of course it's evolving through practice as well. Health Consumers New South Wales, the organisation that my Executive Director here, Anthony, and I both work for, it's the peak health consumer organisation in New South Wales. Now we do receive a small grant from New South Wales Ministry of Health, but we are an independent body and we're member-based. We promote and practice engagement with consumer and communities through health services. And when I talk to people about what I do, the job I do, I say, well, we know that health outcomes are better when patients and carers are involved in the design and the running of health services. And we also know that the health of communities is better when communities get involved in the way health is delivered in their community. And so we help organisations do that better, get people involved. Just looking at that, I came across this. Twitter and the internet's great for the odd meme and image that reflects something that you really understand or tap into. So this really is about different perspectives and having that awareness that everybody can have a completely different perspective, and just because it's different to yours doesn't mean it's wrong. And the more I've looked at community and consumer engagement in health, the clearer it is that the more perspectives that you are inviting into your work or that you're seeking out, then the better outcomes will be. Today I want to cover a number of areas with you. When I put this together, there isn't actually time to get into everything that you find in 40 minutes, but that's okay because we can talk later. And I hope that actually this is in fact the beginning of more conversations. I want to cover some definitions and some context for this area, including touching on where some of the evidence lies and telling you where to find more of that evidence. I also want to cover off different engagement approaches that have been out there in the past and more recently. I'll look at and give you a breakdown of the Health Consumers New South Wales WentWest model we're talking about today, with the context, what it actually is, how it's put together, and how services are and can use the model. And finally, I want to broach the subject of research and evaluation and have a bit of a conversation with you around that. So a couple of definitions, it's really worth getting this up front. There are lots of definitions out there. We see that consumers are people who do use or could be using services, health services. They are the family, the carers, the users themselves. And community are groups of people or organisations that have some common or regional interest, and that can be in health or it can overlap with health. Engagement itself, we see as that is in fact activities that involve the people who use the services in health service decision making and in policy development, delivery and evaluation. It's often called participation as well. Certainly some local health districts strictly really use that word participation. Sometimes they say community participation. Consumer engagement, it generally is a similar thing. What it isn't is we're not here talking about patient engagement in their own healthcare, as important and valuable as that is. But as an aside, if you are interested in patient engagement in their own healthcare, it's really worth talking to real consumers about how to do that effectively. So it applies to that as well. So I just want to cover off a number of the fundamental reasons why we would bother engaging with consumers and community. And a human rights approach or an ethics approach goes right back to, well, it can probably go right back, but I'll put a pin in the board. 1978, the World Health Organization Declaration of Alma Ata. The people have the right and duty to participate individually and collectively in the planning and implementation of their healthcare. It is seen as a human right and a worldwide human right, and that was the same period when the World Health Organization was focusing far more strongly on primary care and recognising primary health care was an important stepping stone for people to live a productive, socially productive, economically productive life. But there are other reasons why we would engage, and some of that can stem in the literature, which I'll just touch briefly on. And one is that it's been shown to improve health outcomes when we talk to people about what works better for them, both in the process of the way it happens and also the actual outcomes and improvements. It also improves relationships between consumers and community groups and health service providers, brings them closer together. And it can also serve strategic and political purposes. That doesn't have to be a bad thing. That can be a valuable thing, particularly if you're arguing why you need more funding in this particular underserviced area. But there are other reasons why all health districts, in particular, local health districts in New South Wales, need to engage, which anybody from a health district here will be very familiar with. And that is mandatory standards, and that's the National Safety and Quality Healthcare Standards. Standard 2 is partnering with consumers. So it's given a fair bit of importance, and that is where there is governance and support in place to form those partnerships with consumers and with families, to involve them in the planning, involve them in designing care, involve them in evaluating services. And it does apply to clinical care, and at this stage it hasn't been didn't apply to Medicare locals, and it doesn't apply to primary health networks. So that on its own is interesting. All of local health districts and hospitals are required to apply that standard, but primary health networks are not. Some of the services that primary health networks are engaging with through their commissioning processes will be required to meet the standard. Okay, so there are good reasons why we would do it, but what's the evidence for consumer and community engagement? Now, we are going to make these slides available, so I have included some references in the slides, and you'll be able to contact, I think, Kelly to get a copy of the slides after today. But also at the end, I will give you a way to access the resources that we've put together on our website, and so you can actually drill in and see more of the evidence if you wish to dig down and see what's there. But the upshot of the evidence is pretty clear. Firstly, that there is limited evidence. It's a bit hit and miss. The reporting isn't consistent. There is evidence, but there's low amounts of evidence. And one of the reasons why there's low amounts of evidence is it's really complex. It's different in almost any organisation, even if they take the same model and same approach and apply it in their organisation, in their community, it's going to be different. I'm sure it probably defies anything like a randomised controlled trial, but I'd love to be proven wrong. The other reason why there's limited evidence is there's often no time and no funding at the end of a project to do that, and it fundamentally won't happen if it isn't actually built in at the start of a project. It doesn't happen by accident because there's money and time left over, is what we find. But the other aspects that come out of the evidence, and particularly systematic reviews, is that engagement with patients, families and communities does show improvement in health outcomes. It shows improvements in health services. And in particular, it's been linked to improvements in outcomes, better service access, better usage of services, and better linkages between communities and services. And there's also been, understandably, as I mentioned, a diversity of approaches across primary health. So we've given you a couple of the key references there. I've got a little bit more towards the end of the presentation about some of the local evidence. I want to talk to you about engagement, because this is a subject that there's been a fair bit about. Arnstein, does anyone know Arnstein's ladder of participation? Anyone here recognise this graphic? Got a few nods. This was produced in 1969, and it's the first evidence of this kind of thinking through. There are different ways of engaging with citizens or with community, and it runs from pretty much, they're saying, non-participation at this end, and you could use the word tokenistic. Tokenistic's actually this one, where it's informing, consulting, placating, and citizen power is partnership, delegated power, and citizen control. There have actually been many iterations of this since that came out back in, well, several decades ago. I'll just for ease of, refer to this, which comes from the standards, the National Safety Quality Healthcare Standards, where it ranges from inform, where you're really just pushing information out to many, through consulting, partnering, which implies some sort of sharing of power, delegating and control. So there's, across that spectrum, a concept of an increasing level of consumer and community control. What tends to happen is that the number of people involved in these activities ranges from many through to a few, and that the intensity of the engagement ranges from lower intensity at the informed level right through to pretty high intensity engagement at the far end. There's a couple of new approaches though that have come out, so you may have heard some new words being used in the last few years. One of the phrases is co-creation or co-design, also evidence-based co-design. These have come out. And they're really talking about, when you read through the material, they use terms like genuine and meaningful engagement. They say it involves consumers and staff and others in actually making real actionable improvements to health services. In particular, the evidence-based co-design focuses on better understanding the patient experience and improving the patient experience. There's a King's Fund toolkit around evidence-based co-design. So both this approach and the next one that I'm going to mention, co-production, while they often say they're beyond, I have read examples where they describe being beyond engagement. In our view, engagement is it doesn't have a particular value. It's either from one end to the other, and engagement can be incredibly intense and incredibly effective. So look, our view of these areas is that they do sit on the spectrum, but they sit at different points of the spectrum. And one thing I would say, while it's I don't want to promote anybody throwing out old words because, well, that was last decade, so what we'll do is we'll take on a new word. But I do recognise that some organisations do actually need to refresh the way they look at engagement, and that can actually be quite valuable, can be what works for an organisation. And we are working with one organisation that really love it. Really, they've bought in, and they are really standing up for the concept of co-design and co-production in their organisation, because that's what means something to them. So we're happy to support them in that. Co-production, just to finish that description, that's where, and it's been used across redesigning public services for, across anything, civic services, even beyond health. And it's where the professionals actually recognise that there's a great deal of value that is contributed by communities and community organisations towards what the general aim is. And we know that health is produced in communities. It's not all produced within health services. Health services treat issues when people have a problem and come in. So this is about recognising that there's great strengths out there and public services coming together, and in some cases really handing over control to communities to say, well, what do you want to achieve, and what do you think is the best way to achieve it, and we want to contribute to that. So a third approach that is really important and worth raising, and I'll explain a little bit about this wheel in a minute, but that's commissioning. Who has heard of commissioning? Okay, a few hands. Okay, well, commissioning is the phrase that's being used for the way primary health networks across the whole country will be designing and commissioning services, and it's in a whole range of areas. So the idea the primary health network is not supplying services, but the primary health network engages with the market and with providers, and particularly with the users of services, to understand the needs and design an approach and put that to market, and then actually have services delivered by third-party providers under contract arrangements. Now, there are as many definitions of commissioning virtually as there are commissioners. So it's still an area that's incredibly in flux. And some people can be using that word, in a sense, in place of the word purchasing, because what they're really talking about is purchasing. The true concept of commissioning was to take that money and bring all the parties together and think in a much more holistic and innovative way about a better way of meeting those needs. That's really was the general idea of where it came from. It's not going to be an easy thing for primary health networks to do, and they will need time to go through a number of iterations to see how it works in their community, and what works in one community and one region won't necessarily work in another region. I've included this cycle in the slides because we recognise it's actually a particularly valuable display of the cycle, because rather than simply putting the patient in the centre to say everything happens to the patient, we're always going to think about the patient, but the patient isn't necessarily involved in the process. In this one, patients are involved, consumers, communities are involved in the analysing and planning, where it's working with communities to identify needs and aspirations. It's working with the public to plan and transform services. It's working with patients and carers to improve quality and safety. Working with patients and the public to procure the services. And again, working with patients and carers to monitor services, so they're actually fully engaged around that cycle. The thing is, we'll see a number of different ways that commissioning is interpreted and implemented in this country. So while I could probably put co-design sort of around the partner area of the spectrum, I can see co-production could actually be a number of different parts of the spectrum, right up to where you're basically handing over control to communities and consumers. Commissioning could actually end up at any point in the spectrum, and it remains to be seen how each primary health network goes about it. And I mean, recognise that they will be learning as they go. There's one more model that I wanted of engagement that I just wanted to put up, and that was Puria's model. And Puria's done a lot of work that I've read in great depth, reviewing a lot of literature and identifying the themes that came out of that. And I've got to say, what you've done here is you have tried to give a pragmatic approach, because one thing about the engagement approaches is they're very valuable, but they don't tell you how to set that up and how to make that happen. Paria's approach is a bit pragmatic and a bit sort of about project management, running through what's the aim, the type of activity, the participants, the preparedness, engagement methods, measurement, barriers and facilitators. They're all really important aspects to run through and to plan, to think about when approaching engagement. Now, one thing that we really wanted to do was to find things that made it easier for organisations like WentWest and others to do this, to do engagement well. And so some of the things that we felt weren't answered with what was out there, including the standard, which is quite specific, but they were, well, how do we actually engage? How do we find people to engage with? And are we trying to engage with communities, or are we trying to engage with patients and carers or consumers? How do we make sure it is effective and it's not tokenistic? And what does it take for an organisation to actually gear themselves up to do that well? It doesn't just happen on the smell of an oily rag. So that was one of some of the many questions that fed into the project that we did. It was through from the end of 2013 to mid 2015 with WentWest, Medicare Local as they were then. And we were focusing on embedding consumer involvement across WentWest, but also to develop tools and resources for use across New South Wales. And that was actually the focus from the outset. So what we did in getting to that, and I must say we didn't start out thinking we were going to develop a model. And it's something that emerged through the work that we'd done and the gaps that we felt were there. So we looked at the evidence in the literature. We looked at industry best practice. We looked at the WentWest context. We looked at the transition to primary health networks and where that was going to leave consumers and community. And we looked at the consumer perspective and had a consumer consultant who actually works full-time at WentWest. She was part of our project advisory committee along in the whole period at WentWest. So before I tell you about the model, a couple of key things. Something that stood right out to us was not all the reasons I gave you earlier about why we would engage, but what was the objective of engagement? Because sometimes we felt that was actually lost in the whole process work of engaging and engaging well. And what we came up with was that the actual objective should be improving care. Improving care so that it's respectful and responsive to the preferences, needs and values of patients and consumers. So we've put that right in the heart of our model. We also did a fair bit of work. Now, bear with us. I've got two resources here today. The brochure, you'll be able to pick up a brochure at the end from the front. We've actually literally run out of these. So we've got about 13 for 13 lucky folks to take away the glossy one, but there's going to be copies that Kelly's making. And that contains a bit of a poster of the brochure. But the other resource, and you can access this from our website, is a report about the model, and it summarises the literature and the findings, the barriers, the enablers of community and consumer engagement, and how we've actually featured that within the model. What I've put up here are the things that we wanted to take in mind at all times and that we would like organisations to consider when they go towards engagement. Firstly is to do no harm, and to be aware that an organisation with all the power of a health service can actually do harm when they set out to work with consumers and community. And I'm sure you would have a sense of what I'm talking about, and that's where engagement isn't done very well, or it's done insensitively, and perhaps there's no outcomes from engagement. There's 6 evidence-based strategies that you'll actually see on the back of the brochure that you can take home today. And they allowed us to pull together, and it's detailed in the report, what we thought were the standouts from the literature and from all of the lists of what's a barrier and what's a facilitator to engagement. And they were: ensure engagement is a priority, because if it isn't a priority, it won't happen, or it won't happen well. address the organisational facilitators, infrastructure, resourcing, processes to actually bring consumers in and how they might be reimbursed for their costs, if nothing else. If those sorts of things aren't in place, it's going to be a stumbling block, it's going to be difficult. Actively include disadvantaged and marginalised groups, because unfortunately it's a fact that if we're not aware of what we're doing in the way that we engage, we may simply get people like us, because if we've just got meetings held at times that suit us, if we've got recruitment processes that require people to fill in resumes, etc., you're actually adding barriers to people who would be wonderful to engage with, but they just feel that's all a bit intimidating. And so by recognising that that's important right at the start, we are better at designing our engagement programs to hear from disadvantaged groups. Building the capacity of consumers to engage, and that's recognising they do need resourcing, they need support, they need a coordinator within an organisation that they can call up when they've got an issue. And really they should have training as well if they're involved in any kind of ongoing way with an engagement program. And trained consumers are really effective consumers, are very effective change agents within an organisation. Of course, you also need capacity amongst staff. Engaging well with people, it's very much a relationship-based business, and it's thinking things through, it's knowing when to ask questions and actually seeking out, is this going to work for you if we do it this way? And not everybody comes innately with those skills, and it is something that's valuable in terms of building the skills up of staff and supporting them in what sometimes can be tough work, but it's also very rewarding work. And last but not least is to focus on outcomes and evaluation and ensure that that is a part of the work from the very beginning. The other thing I wanted to mention before I talk more about the model is it's a complex process, and we've made the model look pretty in a nice glossy brochure, but it's not because the process looks pretty. Just that's what you do, you make it look nice in a brochure. It is a complex process, and you may take a number of deviations when you're going through planning and implementing engagement processes, so it's not a straightforward process. So the model this is what it looks like, and I know you can't read it, don't expect you to read it. What we've got is key infrastructure and key inputs on the left, and we've got key outcomes on the right. But in the centre, we've really got what we recognise as being, this is why you do it. So understanding what the goal is it improving care? Is it redesigning a service for the community? This is the central aspect of what we're doing, and the reason we put it in the middle is because we want to make sure we are actually understanding how the bits and pieces that we're doing throughout engagement feed into and actually improve the care or the health outcomes. The other aspects that I'll just point out to you here on this slide is that we've got an overarching banner which we've called Consumers Involved in Governance. Consumers involved in some form in governance, whether it's governance of the consumer engagement program, it might be governance of the whole organisation. And it's not only an important symbolic statement to say consumers are a key part of our governance structure, but it brings great insights into the organisation from the top down. Guiding principles and values, these are also quite important for organisations, for consumers and staff to agree this is how we will work with each other, respectfully, open communication, transparency, that they're the sorts of things that make their way into principles and values around engagement. There's three key concepts right at the centre of the model. I've talked about consumer-centred care. Up the top, we've got something we've called top-down engagement. And down the bottom, we've got something we've called ground-up engagement. And what we've done is recognise that actually health services do engage in different ways with different groups. Consumers of services, users of services, these are people that we want to understand, well, what's your experience of the service? And can you help us evaluate the service? Would you like to help us design this new aspect of the service? So it's direct engagement with people who do use or have used a service or their carers. Whereas ground-up engagement, that what we're talking about there is going out to communities to find out what we don't know. We don't know how to bridge this gap, or maybe there's gaps we don't understand. Maybe utilisation of a service is low in an area and we want to understand why is that. Probably not because they don't need it, but it's probably because what they need, what we've provided doesn't meet their needs. So in a sense, the top-down is often agency-led. We're setting out to find out certain things. Often a lot of standard 2 accreditation fits in at this level. But ground up is the areas might be services we don't know we need yet, or services that we really must get the advice of the community before we set out and design them. So as I said, service focused for top down, initiated, usually known health needs, usually existing or planned services. I've got an example which is in the brochure, and it is Alison Kakani is on the right, and she's the consumer consultant that was our consumer rep on the project in WentWest, and she's working with another consumer there. And the Partners in Recovery program through Medicare Locals is a program for people with persistent and long-term complex mental illness. And it was a program that actually coordinated quite a number of services, including social services for those people. Phone surveys were not getting any kind of they weren't getting much response. So what they did, sorry, that was a survey by letter. That's right, they were invited to participate. What they did is they actually got a consumer involved, and that consumer actually rang the clients of the service. And these are vulnerable clients, but through that personal contact, they had a far more effective response rate to that service evaluation. And not only that, not only was it more effective, but when problems arose, there were problems they could solve pretty much immediately, and even solve for those particular clients. So there were system changes, system improvements that came out of it, but there were also improvements one-on-one for those people that participated. Now, with ground-up engagement, as I said, community focused, it was important for us also that communities can actually initiate this service. Now, initiate ground-up engagement. I think that's really quite out there for most health organisations to have channels open for communities to say, look, we want to work with you because we want to do this. Some organisations respond really well when a community group is sort of banging down the door saying, look, we're not satisfied with this, we really want to work, we really want something better. Some organisations can do that, and some find that can get defensive when they're in that situation. But it's an interesting area. Is your organisation porous? Does it have ways that you can hear from different community groups what's going on and what their needs are? And an example at WentWest was a program that was run through Mount Druitt. It's been running for a little while, and it was run with several service provider partners. And the focus was early intervention with children, preschool, so the 0 to 5 age group. And to work on it's well documented that the health of a child when they start school can often will have a massive impact on the sort of life course. So they worked with community. They also interviewed and got community members and families involved in a coordinating committee. They did active surveys with a simple question at every event that they went to and pulled that information together. And they really brought those community members and parents together to determine what that program would entail. And it involves everything from baby rhyme time, where parents bring kids together and they read nursery rhymes together and actually encourage that active reading to a child, which is also shown to have an incredible impact on their development. And also Tiny Tots Soccer, where they get the kids involved and it has a huge impact on their social skills. Many of these kids actually don't have preschool before they start school, so their level of social interactions can be incredibly low, and that's one of the areas that the program has focused on. I haven't really done it a full justice there, but Thrive at 5 is what it's called. It's a really lovely program at Mount Druitt. That has brought many service providers and community together. Right, just check the time. I won't dwell too much on these aspects, but there's more information, as I said, that you can access if you're interested. When we work with organisations, we encourage them to go through each element of the model to say, well, if reviewing the critical inputs, reviewing that internal capacity, the key staff roles, the accountability. If there isn't accountability for engagement across an organisation, if there's one person who's in charge of consumer engagement, the risk is that everybody thinks that person does it. Whereas in fact, everyone responsible for services, for quality improvement and measurement, it should actually be shared across the organisation, and I believe that's really where you need to have responsibilities built into job descriptions. You need that accountability and that governance. The other argument for doing that really well is passionate people come, do a great job and then go. And when passionate people go, if you don't have a real infrastructure that supports doing this well, that has integrated engagement into the way the organisation does business, you lose it. So it's well, how does that engagement feed into the quality system? How would you know if the engagement that you had done with consumers and community, how will you know if it made a difference? How are you tracking that? How are you recording that? And that was really important to us that came through in this model. No, it's not easy, but they're really good questions for organisations to be thinking about. Partnerships and integration. Consumers don't think of themselves as split across silos of healthcare, so when we engage with them about their health, they need to be able to talk to us about their health across any organisation without us going, no, stop there, no, we're not responsible for that bit, we want to talk to you about this bit. And the capacity, of course, of consumers and community, it's something that organisations do need to plan for and budget for. And of course, we talk to them about monitoring and measuring outcomes and how they can plan for that and how they can do that effectively. The last point is capacity and capability building, which is slightly tenuous, but it's recognising the model that we drew. It's a process model. What it doesn't show you is actually organisations that participate in engagement and do it well, they keep doing it well and they keep building on a network and growing a network and building the relationships around that network. And that's actually what makes an organisation perform really well in this area and get a lot of benefits from consumer and community engagement. They're building, every time they do it, every time they run through a process or every year they've effectively engaged consumers. They're building capacity for their own organisation, but the capacity of the consumers and the community that they're working with. They get good at working with us too, and an effective consumer is one that challenges you, that doesn't necessarily agree with everything that you're doing. So just finally, in the way that that organisations are using this, I don't expect you to read this, but it's something that we've made available recently and to particularly primary health networks, but others, which works through the model to say, well, start here. What's your goal? What are you actually seeking to achieve? And then based on that, should you be engaging with consumers or community or both? And what would that look like? How would you, and then what approach would you take? And then all the key questions down here. So do you have internal governance? Do you have support for staff? Do you have joined up engagement across the providers? Or are you expecting consumers to break up their involvement? And equally running across the monitor and measure. So just before I move off that, one of the things that we would love to see, this model, I'm sure it's not perfect. We think it's good, but we know it's not perfect. And we'd love to see more organisations use it, and we would love to have it evaluated. So that's certainly something that we are open to and would love to see happen. I'm not quite sure how yet. But certainly it's something that I think would be worthwhile for the Australian context. Because while we set out to build it for a PHN, we're finding it's actually, many organisations across the country are finding it's relevant to them too. So then to talk just a little bit about research and evaluation, I promised to let you know, that's the next slide. So there is research into engagement in the Australian context, but it's limited, but it's good quality. I do want to clarify though, because I know that we could have, there's a number of people in the room who probably wear a few different hats. This research that I'm talking about, I'm not actually referring to involving consumers in research, even though that's a really important thing to do. I think I know what I'm talking about is the effectiveness of consumer and community engagement in health services, what a difference it makes, the impact it makes, what approaches are working, what approaches aren't working so well. The intersection is research into the impact and effectiveness of involving consumers in research, of course, and I'm always interested in that too. So the local evidence, southwestern Sydney, so Linda Johnson, who's been the community participation manager there for a number of years, and who knows Linda Johnson? Does anyone here know Linda from southwest Sydney? She's if you ever get the chance to hear her speak, she's fabulous. She will call a spade, and she's worked incredibly hard to advocate for consumers in that health district, and probably has the gold standard sort of framework and approach in a health district that I would be aware of. We're learning from her. So, but Linda, together with Dr. Sally Nathan, conducted over a couple of years an impact evaluation of that particular framework and that local health district. They, over time, measured, interviewed, surveyed, got the views of staff and consumer representatives of what they felt was the impact of engagement in the organisation. They've had many actionable findings about real outcomes, process improvements, staff even saying, well, we've actually found that meetings run better when consumers are involved. But also attitudes to personal story and role, and we've used them in training. The fact that some staff don't understand or find difficult that consumers can very effectively tell their own story in the context of engagement. Now, it's great for consumers to learn effective ways of doing that. Sometimes if a consumer is always talking about their one story and doesn't relate it to where the topic of discussion, it may be that actually they weren't ready to move into that role at that stage because they were still dealing with what had happened. Whereas personal story is an incredibly effective way to reground the conversation and the issue at hand, and many consumers do it really well, actually. Again, it's training can actually help them understand how effective that can be. But staff have sometimes found that challenging, and I think that's probably through the background of their training, where you never bring personal, into the situation. But just bringing that into training to make sure that it's an awareness thing for staff to appreciate, to learn to appreciate, to learn to hear, to learn to act on the personal story of consumers that they're working with. But another one is role, and that is when its impact is considered more effective when staff understand the role that consumers are playing and consumers understand the role. Sounds like 101, but it's not. People who are in the early stages of setting out to engage often say, well, we need a consumer, but haven't yet thought through. It's always one of the first things what do you want that consumer to do? What's their role in that particular project or committee? And it's important for selecting the right consumer as well. So what is now extending that local evidence is the research protocol they developed for southwestern Sydney is now being adapted to Western Sydney. Their chief investigator is Dr. Coralie Wales. She's the participation manager at Western Sydney LHD. And again, they're aiming to understand the impact of consumer engagement across the organisation from the points of view of staff involved and consumer reps. And they're implementing, they've been implementing for the last year or so, their own engagement framework. So that way they'll be able to report back on the impact based on, it's based on views. So it's beyond process, it's impact as well. But there's room for more. And what I wanted to do was, and Meredith's going to help, I believe, facilitate this, was to certainly open up for questions, but some of the questions I wanted to put up, if anyone's interested, is what you think might be the barriers and enablers to evaluating health consumer engagement more. in New South Wales, in Australia, and opportunities that there might be to conduct and publish research into consumer and community engagement. We'd really like to see a lot more of that happening, but also happy to answer any other questions that you may have. One thing I can't answer for you is the way a particular organisation handles a complaint. There is a consumer body that represents Nepean, certainly the Health District. I don't know if you're aware of that, but that there's an organisation you can contact of consumers if you wanted to take it to them. They can't solve a complaint, they can't handle a complaint, but what they can do is to put the story to the... I'm assuming you've gone through a number of avenues, but there are other avenues that you might be able to go through. But look, I can't answer anything else today about a specific complaint. Complaints are actually an incredible resource for organisations to front up to what they might have to actually, fix. And we know some people who've taken a pretty heavy-going complaint that's involved the illness and then the death of a loved one, and that person complained. They were treated with great respect, so that organisation's done a great job, and they went through a process. That person is now an amazing consumer advocate. So she's gone from being a family member making a complaint. She went to an organisation that listened, respected her, gave her all the information she wanted. The right people were there, the CEO was there. She had the personal agency because she was fortunate enough, she came from a professional background. She had no problem sitting in front of those people and saying, this is what I think. And then that organisation has responded very effectively. Her story now is involved in training all staff of the whole organisation, and she is speaking, is an active advocate speaking to promote everything we've been talking about, to promote listening to complaints, to talk about how you can do it effectively. So it's possible for that processes, as messy and difficult and scary for an organisation as they can be, as distressing as they are for consumers and family, it's possible to actually turn them into a good outcome. I would say they are.
They are.
They can, but I would say they can be. So once it comes back to how well, how well is it planned? How meaningful is it? Does the organisation have a track record? If there's an organisation forming a partnership group, then how have they gone about doing that? How do they go about improving on that? How do they listen to what the partnership group has to say? Every primary health network and every local health district, so health across New South Wales, is required to have, at some level, to form a council or a committee of consumers and community members to advise them. So
isn't the responsibility of primary health networks?
It's their responsibility to form those groups, and they form part of the governance of the organisation. Primary health networks in particular, they have two peak councils. One is a clinical council, one is a community advisory council, and they report to the board of the primary health network. So that's an example. So, but at the same time, every primary health network will do it slightly differently. They can all write their own terms of reference, but they are required to have one. And similarly, local health districts, through the standards, are required to have some form of consumers' community involved in the governance of the organisation. Well, you'll love this answer because it all depends. But if you had a long-term program where it was all going to be in a similar area of health, then it would be, I would recommend you actually really established a group that you would train up and work with in a long-term sense. But if your research topics change and come and go, the particular focus of the research, then the consumers that you would involve will change. Or they might be brought on for that research project, follow the research project through, and then remain in contact, or the project finishes. So, as I said, it depends. And if the research topic could be something where there's existing consumer organisations like Diabetes New South Wales, or Osteoporosis Arthritis New South Wales, there are other bodies around, cancer bodies, and you might be able to go through them to request consumers. Health Consumers New South Wales is always an option because we have a range of consumers who are members. We can also advise you. We're available for advice. We can actually work with you in a greater capacity as well, all depending on what you need. But sometimes it might be worth designing an ad and actually putting out an ad for people who have had an experience with X. Would you be interested in participating in a research project? Again, that comes back to you being clear about what the involvement is, and then, so what are we looking for in a consumer? And we've got resources that others have used in the past about what are we looking for in a consumer representative that can help. And for everyone they might, so that's what we want, but we'll change it a bit here and there because this is what we need. And so, I mean, honestly, advertising or going to the community health centres where you'll find people experiencing whatever it is you're researching, you know, going to the places and putting up an ad. Sometimes ads with tear-off numbers in the right location work for recruiting consumers. Yeah.
Excellent. Well, that's been a really interesting and passionate session, and I really thank you all for becoming so involved, and I'd like to ask you to join me in thanking Serena for her